This is week 9, fetal treatment. The objectives for this week are to describe the indications for and capabilities of fetal transfusion, fetoscopy, pubs, and fetal MRI. To describe indications, methods, risks, and benefits of in utero treatment using congenital adrenal hyperplasia as an example, and to describe indications, methods, risks, and benefits of in utero surgery using spina bifida as an example. Chordocentesis, or percutaneous umbilical blood sampling, PUBS, is a diagnostic prenatal test in which a sample of the baby's blood is removed from the umbilical cord for testing. Now, this test is usually done after week 18 of pregnancy, and it can be used to detect certain genetic disorders, blood conditions, and infections. It can also be used to deliver blood transfusions or medication to a baby through the umbilical cord. This test is used primarily to detect and treat blood conditions such as fetal anemia. The use is decreasing because it's been replaced with amniocentesis and chorionic villus sampling. And these two prenatal diagnostic procedures pose a much lower risk of fetal loss. It, however, might be necessary to utilize this PUBS if other prenatal tests don't provide enough or sufficiently timely diagnostic information. This is a picture showing how PUBS works, where you go in and you take a fetal blood sample from the umbilical cord and you utilize the ultrasound too for location of the fetus. The risks that are associated with PUBS are fetal bleeding. Bleeding from the area where the needle is inserted is the most common complication. A cord hematoma, where there is a collection of fetal blood within the cord that might occur during or after the procedure. The slowing of the baby's heart rate, which might happen temporarily after the procedure. An infection, this is rare, but it can lead to a uterine or fetal infection. Fetal maternal bleeding, where the fetal blood might enter into the maternal circulation. This can occur in about 40% of the procedures. The amount of bleeding usually small, and the problem is more common when the placenta lies in front of the uterus. Pregnancy loss. This procedure carries a higher risk of fetal loss than other prenatal diagnostic tests such as chorionic villus sampling and amniocentesis. The risk is about 1.4 to 1.9%. In looking at MRI, it may be used to provide more information about a defect that has been detected in ultrasound images. One of the important advantages with MRI is it does not use ionizing radiation, and it has high soft tissue contrast and resolution. It provides a highly accurate depiction of the morphologic changes of development in the normal brain and in the fetal brain disorders. It can be performed several times during pregnancy, and this permits the documentation of the natural history of the brain injury over gestational age. MRI can also be used post-mortem for macroscopic analysis for central nervous system as well as non-central nervous system anomalies. Looking at the risks associated with MRI, you have to be cautious to use it only during the second and third trimesters. There are fetal safety concerns that are related to teratogenesis and acoustic damage. MRI is usually done from 18 to 20 weeks gestation or later. And before 18 weeks, ultrasound is able to identify severe malformations. Intracranial anomalies can be missed in the second trimester, so MRI is optimally performed in the late second or third trimester. The indications for using MRI are abnormal ultrasound results. Ventricular dilation is the most frequent indication for using MRI. A CNS malformation or brain injury, or such diseases as X-linked hydrocephalus, tuberous sclerosis, and neurofibromatosis type 1. I would like you to go to Children's Hospital of Philadelphia Center for Fetal Diagnosis and Treatment and to look at some of the newest types of fetal surgeries that they are now performing. We're now going to look at treatment of congenital adrenal hyperplasia. Prenatal virilization in an affected female fetus can be prevented today by administering with dexamethasone, DEX. The treatment offers a means to prevent having to have genital surgery after birth. However, it has to be initiated in the early first trimester before prenatal diagnosis with chorionic villus sampling is possible. The concern is that DEX may have a negative side effects in the fetus, the growing child, or later in adult life. The fact that only 1 in 8 treated children will have a direct benefit of the treatment has also added to the ethical concerns of utilizing this means of treating the fetus. And there have been maternal side effects in 25% of the women that have been given the DEX treatment while they were pregnant. And these include excessive weight gain during the first trimester of pregnancy, stretch marks, mood swings, irritability, insomnia, edema, and general discomfort. The DES treatment does not have major teratogenic effects. There have been few follow-up studies on the developmental outcome of the DEX-exposed children. Only one study has been based on direct assessment of the treated children utilizing neuropsychological tests. The results from this study have shown that the DEX treatment has long-term effects on verbal working, memory, and aspects of self-perception. However, there have been no major behavioral problems seen, and there has been no long-term memory or IQ effects found. Analyzing fetal DNA from the maternal circulation is holding promise, and it could potentially eliminate prenatal treatment in male fetuses for CAH. Glucocorticoids have been used in mid-trimester to promote fetal lung maturation before an impending premature delivery for a while now. However, the dose that is used of the glucocorticoids for CAH prenatal therapy is much higher. Prenatal therapy should not be used at all in families with mild forms of CAH. There are 3 types of spina bifida, and they range in severity from completely harmless and undetectable until an X-ray is performed later in life to the spinal cord actually protruding uncovered from the back. And they are spina bifida occulta, meningocele, and myelomeningocele. Fetal surgery for a myelomeningocele is a delicate surgical procedure. The fetal surgeons open the uterus and close the opening in the baby's back while they're still in the uterus. And the surgery is shown to offer significantly better results than the traditional repair after birth. This is due to the fact that the spinal cord damage is progressive during gestation, and the prenatal repair of the myelomeningocele may prevent further damage. Fetal spina bifida surgery is one of the most exciting developments in the history of treatment for birth defects. It's an extremely complex procedure available only to qualified candidates. It requires significant commitment on the part of the mothers who choose to go forward with it and extensive surgical experience to perform this procedure successfully. The prenatal repair of the myelomeningocele is performed between 19 and 25 weeks gestation. Mothers require close monitoring for the duration of their pregnancy. In prenatal repair, the mothers receive general anesthesia, which also relaxes the uterus and anesthetizes the fetus. The fetal surgeons perform a laparotomy, which is an incision across the mother's abdomen. The uterus is opened with a uterine stapling device that pinches off all blood vessels and keeps membranes secured to the muscle. A maternal fetal medicine specialist performs sterile intraoperative ultrasound to map the position of the placenta and the fetus, and the baby's back is rotated into view. A pediatric neurosurgeon removes the sac, if one is present, returns the spinal cord to the spinal canal, and closes the surrounding tissue and skin over the defect to protect the spinal cord from exposure to the amniotic fluid. The uterus and the abdominal incisions are then closed. During the surgery, a fetal cardiologist uses echocardiography to closely monitor the baby's heart. All of these measures are used to ensure the utmost safety of both the mother and the baby. Mothers usually remain in the hospital for 3 to 5 days and are on modified bed rest for 3 to 4 weeks after surgery to reduce the risk of preterm labor. The remaining of the pregnancy, follow-up includes weekly visits to the hospital for ultrasound monitoring and routine prenatal care. If labor does not begin sooner, the baby will be delivered by planned cesarean section at 37 weeks. This is a slide showing the prenatal surgery for spina bifida that I just discussed. So after birth, some of the things that are done to look at the health of the baby is head ultrasounds are done on the day of delivery and prior to discharge. An MRI is done to evaluate the baby's brain and spine. Daily head circumference measurements are done. Renal and bladder ultrasound is done at 2 days old. Bladder scans are done to estimate the amount of urine in the bladder and whether the baby will require a catheter. And clean intermittent catheterization of the baby is done to see if the baby's bladder volume is greater than 50% of expected volume. Urine flow rate and the time needed to empty the bladder is also measured. Measures to prevent urinary tract infections are employed, and an evaluation for a shunt is done. It's important to remember that fetal surgery for spina bifida is not a cure. Studies show that the prenatal repair can offer significantly better results than traditional postnatal repair, and that fetal surgery for spina bifida greatly reduces the need to have a shunt to divert fluid from the brain when hydrocephalus forms. And also, the fetal surgery has been shown to improve mobility and to improve the chances that a child will be able to walk. Please go to this link to be able to see Children's Hospital of Philadelphia and their breakthrough surgery on spina bifida. This week's quiz, which you will have 2 weeks to complete, will have questions from weeks 5 to 8. I did not include week 9. And there are questions on syndromes. There are questions, the questions are there so that you have to answer the short answers. There are no multiple choice. And you will have to do some fill-ins.